Hydralazine was probably one I would recommend. And when I was looking through the medication, I I was looking at his history too. Actually, you can actually increase the bioavailability of hydralazine with food if you take it with food. And I
Yeah.
noticed that he was having some of his low systolic blood pressures or fainting spells, sorry, after showers or after meals. So I wasn't sure if maybe he was taking his hydralazine with his meals. Since it was TID, that's usually what we tell patients to do so that they help them remember it.
Mm.
Uh, so the recommendations is not that you shouldn't give it with food, but that you just want them to be consistent. And if they're going to take it, they should always take it with food. But for this frail individual, that might have been maybe he's absorbing it faster because he was taking with foods and contributing to his hypotension. The other thing I was concerned about maybe was the doxazosin. Alpha blockers typically are
Yeah.
commonly cause the orthostatic hypotension. And I don't know how severe his overactive bladder was or what his history was also, if he could maybe be tapered off that.
So actually, what I did, I took off the hydralazine first because that's when he started fainting. He wasn't quite fainting on his old regimen, but I was concerned about something called postprandial hypotension in the elderly, in this elderly patient with lots of comorbids. He's not too verbal. He can't tell me how he feels, but there is such a thing. So when they have 3 larger meals a day, he's not a good eater, but he eats 50 to 75%, and he has his Ensure. But the what do you call this? The circulation of the splanchnic gut tends to be more active because it's digesting. So we did non-pharm on him actually to kind of get him to stop fainting. Instead of giving him 3 larger meals a day, we started giving him smaller, more frequent meals. I think the family got it to 5 meals a day. So it wasn't like full meals. It was more like snacks, milkshakes, Ensures. And that actually got him to stop fainting because his gut would take all of the blood and give him a relative hypotension. He would do the same in showers because they gave him hot showers. So he would vasodilate and then faint. So they started bathing him by parts. So they do the arm, dry that off, do the other arm, dry it off, do the trunk, dry it off, little by little. And he actually stopped fainting based on those, and his blood pressure was a little more steady throughout the day. So non-pharmacological measures do help regularize your blood pressure as well. He actually started gaining weight with small frequent meals because he was encouraged the whole time. We did take him off the memantine because he was kind of a little further on in his dementia that it wasn't really of much benefit anymore. So that got weaned. The doxazosin we were able to cut in half because his BP, his urinary retention wasn't that bad. We tried to take it off entirely, then he retained, so I had to give that one half dose back. But strangely, we were able to wean him off the sertraline. They thought he had a lot of apathy and lethargy, but when he started fainting less, and he became more alert, really, because he wasn't like fainting every 2 times a day. And then he started complaining about what the housekeeper was putting on the TV. Said, I can't understand that, change the channel. So he was more aware of what was going on around him. So little by little we did that. I think I was able to decrease the labetalol, but could not entirely cut it because he was rebounding. So it's a gradual process still with him.
Any other comments or questions?
So yeah, he was definitely over medicated, I feel. I mean, that's 4 blood pressure pills. He didn't need the 4th one to begin with.
I just want to say it's an interesting observation, and I understand. That's why I kind of wondered, that Partridge study where they looked at, does the level of alertness, their quality of life improve when they stop all the medication, right?
Yeah.
Because anecdotally, I see that too.
Yeah,
just like
people
you
wake
saw.
up.
they wake up, right? Yeah. And it wasn't detected on the study. The only thing that came up was that orthostatic hypotension improved, right? So I kind of wonder if it's a proxy of that orthostatic hypotension as opposed to just the blood pressure med. So I think that was kind of interesting because anecdotally, that's what I see too.
Yeah, so we got him down 1, 2, 3 medications off. He wasn't a good eater, so I stopped his calcium and the ferrous sulfate and the vitamin A. And actually, because he wasn't a complainer, you know, he was not too verbal, we started weaning the gabapentin too, and he didn't seem to notice. It's just that he was kept on that med for years. And that could also cause his autonomic to be maybe a little off, I don't know.
Right. So what was his ultimate blood pressure?
Right now we have him around, let me open my notes, but he runs around 140 to 150. When he goes to 150, it's okay with me. When he starts going to 160, I start looking a little bit. Then he'll go down to 120, 130. But he doesn't go beyond 150 very often. And it was kind of strange. It was counterintuitive. I took off meds and he became more steady. He wasn't fluctuating throughout the day, kind of. And I think having him on the frequent meals and showering him in parts really helped too. Yeah, just those simple non-farm measures. Yeah. Yeah, because physiologically, his autonomic cannot handle.
Memantine is also reported. It's still pretty low incidence, but it can increase blood pressure as well. Probably about 4% incidence of that. So stopping his memantine maybe helped lower his blood pressure as well.
Yeah, possible.
Interesting.
Yeah.
Does this trigger anybody else's mind for cases that they have they might want to share?
But usually if you see patients in a lot of meds, they don't need all that more than half the time.
Does anybody else have patients where their blood pressures are super high and then they drop super low?
This is Mary. I had a lady in her 90s who was some kind of dementia. We couldn't really assess what it was because she'd get very angry and fire anybody that tried to do any cognitive screening on her. She was very much in denial that there was any changes in her, but she had 3 blood pressure meds, ACE inhibitor, alpha blocker, and the hydrochlorothiazide. And, she was really messing up her meds. And there was this period of time where she was falling frequently, and it was really bad. And but then as her dementia progressed, and she kept telling us she's taking the meds, and she'd list off all the things when she took them, but you clearly could see she hadn't taken them for months. After that, she didn't fall again. Yeah, and her blood pressures would, I don't have her anymore, but her blood pressures they're pretty labile, but it would go kind of high if she was really mad about something, but generally speaking, it wasn't too bad. Maybe something like that, maybe 160 over 70 something. What was scary about her that was really weird was her heart rate was often like 39.
Yikes.
And I'd say, are you feeling, oh, I feel fine, everything's fine. She looked the same whether it was 39 or it never went up very high, but the family didn't want any assessments done. They didn't want anything done. She lived alone, and even though they tried to hire somebody, she wouldn't let them in when at the time she wouldn't let anybody tell her what to do with her meds.
I guess she knew better.
She thinks she did.
Oh, one thing I forgot to mention on Dr. T, we put TEDHOS on him too.
Yeah.
And that helped a lot because every time he would transfer, then, when they would help him from wheelchair to bed, then he'd faint. So we put some TEDHOS on him that eliminated that. So
right?
Yeah.
Yeah, and I actually, you have to tell people to get up slowly.
Yeah.
Right? You sit at the edge of the bed, you dangle a little bit, you pump your legs, then you
So-
stand up and you wait another minute or so, and
Yeah.
then you walk.
So every time I see him, I'm whittling down on his doses, actually. I don't want to do it too fast because I don't know why they were started to begin with, but so far so good.
I have a question or a case, and I want to hear what you guys had to say about it. So this is a 67-year-old man, and so he's still fairly young and not much history going on. All I have is that he has hypertension, gout, asthma, and BPH. He's on amlodipine 10 milligrams, finasteride 5 milligrams, and then the combo losartan hydrochlorothiazide, and the tamsulosin 0.4 milligrams. And his blood pressure on two separate occasions, 140s over 50 to 60s. But he said he actually stopped taking the losartan hydrochlorothiazide because he gets dizzy. I don't exactly know how he figured out that it was that one that's making him dizzy versus the amlodipine. And I'm not really the PCP because I just see him for like a once a year assessment. So I wasn't sure like what to do. I mean, aside from telling him to go back to his doctor, I just suggested maybe you could try taking the blood pressure medicine separately instead of both amlodipine and the losartan at one time.
Did his blood pressure go up again after he stopped his losartan hydrochlorothiazide? Or is he at 140, 150 without it?
He doesn't check it at home, so I don't know.
Well, I think he's really smart. The first thing I would cut would be a diuretic. And I don't know how high the hydrochlorothiazide was in him, but he probably had some kind of relative orthostasis. That's why he felt dizzy.
Yeah, it's the 100/12.5 milligram combo.
Okay, so 12.5. Yeah, so it would still be the first thing I cut because it's a combo. In general, I don't like combination pills in the elderly because, as you said, how do you figure out which one it is, right? So, and then you generally start slow and go slow with everything, weaning, starting. I don't know if this was the last medication he was started on, and then he started to feel dizzy. He could be very right.
Yeah,
okay,
patients generally
they know.
know.
Yeah.
And the other thing I want to mention, especially in Hawaii, I mean, it's true for elders everywhere, but especially in Hawaii, dehydration happens very easily because they lose their perception for thirst. And so they may be outside, out and about, and they don't carry a water bottle. I mean, how many elders do you see carrying a water bottle out there?
How many regular people do you?
How many regular people carry water bottles out there? And then, because oftentimes they don't, right? And because they don't want to go to the bathroom or whatever it is. Yeah. So that is often they may be doing fine for like most of the time, but maybe once or twice a week they're not drinking enough, and then that's when they feel extra dizzy. And so if those people are extra prone, maybe we need to just make sure they drink enough first.
Yeah.
And you also raised another really great strategy, which is sometimes it's the timing of the medication.
Yeah, you can
split it.
Split the dose. Have some of them, I don't like telling people to take diuretics at night because they're going to get up and pee and they might fall and they can't sleep. But if ever you need a diuretic, I would suggest for it to be in the morning.
Like everything else.
But the 140 over 50, if he's off the losartan hydrochlorothiazide and he's around 140 over 50, I'd leave it. I wouldn't, I'd observe from there and see how it goes. It's not that bad. And then you might be able to just restart the losartan back slowly if it's really bad again.
So there wouldn't, so you wouldn't say, like, would you suggest he doesn't need that intensive BP control?
I don't know. My question was his BP 140 over 50 on only the amlodipine?
I think the time that I saw him, yes, he wasn't taking the losartan anymore.
Okay, so it's not that bad. If ever it starts being bad, maybe you can start the losartan alone slowly.
Yeah.
Because he was in 100, yeah? So that's a higher end of the spectrum for losartan.
Yeah. Just drop the hydrochlorothiazide.
Yeah, drop the hydrochlorothiazide. But even if you added the losartan 100 on a 140 over 50 blood pressure, you might be dropping him to like really low. We don't know. But that's why maybe he was dizzy. But that's why I tend to not like combination pills in the elderly. I know they say it's better for compliance and whatnot, but then you won't be able to parse out the side effects later on. Yeah.
Okay.
Any comments, Cameron?
I would still also, if he was still getting dizzy, look at the tamsulosin. That class in general,
It does. If
high
ever,
risk for orthostatic hypotension.
if they really, really need it and he can't pee it, take it before you sleep.
Okay.
Or get reevaluated by the urologist. Maybe they can get a TURP or something.
Yeah.
And that
He's
will
still
take care of
young
the problem.
enough.
Yeah.
Still young enough to be able to do a TURP.
Yes.
Okay.
Yeah, my guy, Dr. T, no can, he's 94. And he's
No TURP.
isn't too verbal. I wouldn't send him to get a TURP done. With a bad AS, I wouldn't do it.
That's great. Any other questions or cases to discuss? This is your time. You can ask.
Are there specific articles or on guidelines for geriatrics out there?
No. Well, I tried to put together as best as I could the most recent data.
Okay.
That's what's out there right now. It's, as you can see, over the last 3 years, it's changed a lot.
Yeah.
And that's kind of
it's
where
very individualized, I would
Yes.
say. So I think maybe that's why we can't really have guidelines, because the spectrum of the elderly we see is very different. You have healthy elderly and you have frail elderly, and you don't really just look at the age, you look at their functionality. So I think that's really difficult to come up with concrete guidelines just based on age.
Yeah. So if they're really young, physiologically young and functional and still living in the community and still running around, I think the aggressive treatment management is probably fine. But keeping it within that J-shaped curve of 135 to 145 is probably just perfect. It all comes back to that 2010 J-shaped curve. That's probably where we should probably target. And be a little bit more lax, especially if they have, a lot of, if they're frail, have cognitive and functional impairment.
Okay.
I hope that helps.
Yeah, it does.
So that's why, that's what it is. You have to balance all those things with, of course, the proven benefit of decreased mortality. Because mortality isn't everything.
You can live long, but if you're not living
Miserable.
well, what's the point?
I have a question. So what is the parameter for diastolic blood pressure that you would not necessarily add medications or increase their medications to try and get their systolic at goal? Because I know in the elderly that's usually a problem as well, that diastolic tends to be low, but their systolic is still elevated.
I kind of tend to focus more on the systolic, because usually if your diastolic is going down, so is your systolic. I rarely see like a very, very big gap there.
In my literature review that I've looked at all these papers lately, this diastolic wasn't correlated with anything.
No.
It's not correlated with mortality, improved mortality or improved outcomes of any kind, and so it's pretty much they focus on the systolic. So I don't care too much. Diastolic is.
Me neither.
I mean, you know, I might get a
I mean,
little
I care if
alarmed.
it's like 20, but if it's 50, like in your guy, it wouldn't bother me.
What if it's really high, like
Like
over
100?
100, like 110,
Well, what's the-
114, 120,
Is
and,
that?
and the systolic is high but less than 200?
I would still manage that. Because usually if you see the diastolic going high, so is your systolic.
I was just concerned this lady had, I'd go once a month and check her blood pressure would be like 116, one at the diastolic, and I was,
Yeah.
man,
That's pretty bad.
I kept calling
For the
the clinic and telling them, but they,
Nobody addresses it, but I generally like to keep it under 100. I don't know.
Evidently when she went to the doctor, it would always be under 100, so they said it's fine.
Oh, they didn't like believe you, or
No, it wasn't that. They
Uh-huh.
just said that, you know, they didn't see any problems, so they weren't going to do anything. So I don't know. Yeah.
I would maybe if it's 160 constantly, I would do something about the systolic.
Systolic was higher, but anyway, the last time I went to see her, it was both was good. Nothing to worry about. So I don't know what the deal was with her.
Any other questions from anybody?
Maybe she was angry.
She doesn't talk.
She really doesn't talk. Okay.
She's not gonna-
Questions, thoughts, ideas? You're a quiet audience.
Is there anyone writing in
Oh.
chat?
Is anybody in the chat box? No.
Okay.
Okay. Well, thank you so much for joining us. Glad that that you were, and hopefully you'll join us again. And of course, bring your challenge geriatric cases to us. Any topic will be fine. We're happy to just talk about them.
Are you still doing the premium for the cases?
Yes,
You should
we
mention
are, and we are giving rewards for people who present a good case for a $150 gift card, and Katrina Liu gets that today because she came up with a case presentation. So why don't you email John, and we'll get that to you.
What a surprise. Thank you.
Thanks, Christina.
I enjoyed. I think I learned something new. So that was really helpful. Appreciate it.
You're welcome.
Thank you. Welcome back again, and invite your friends. All right. Bye.
Bye.
It's a Visa card, yeah?
Yeah, it's a Visa card. It's
Yeah.
a gift card Visa card.
So it's
Yay.
Yeah. We'll
you don't you're not bound to like any one store. They can
Yay,
shop
Katrina.
Yay. Okay. Have a great evening.
Bye.
Thank you. Bye, everybody.
Bye.